Hello everyone, my name is Phoebe Marty and today I'll be presenting infective endocarditis in the ICU. The following are the objectives of the lecture. At the end of this lecture, you should be able to list the main pathogens of infective endocarditis, discuss epidemiology, risk factors, clinical presentations, and pathophysiology, evaluate pharmacologic treatment options, and given a patient case, design a therapeutic treatment plan. The following is the roadmap for the rest of the lecture. This is the patient case that will be covered throughout the lecture. At the end of this patient case, there are a couple of questions for you to keep in mind during the lecture. So what is infective endocarditis? Infective endocarditis is an injury such as inflammation to the lining of the heart valve due to infection, drugs, or trauma. Although endocarditis is often referred to as acute or subacute, depending on the pace and severity of the clinical presentation, it is best to classify it based on the etiologic organism, the anatomic site of infection, so either a native valve or prosthetic valve, and the pathogenic risk factors. Endocarditis occurs in about 15,000 to 20,000 new cases each year in the United States alone. In the 1920s, the age distribution used to be less than 30 years, mostly due to rheumatic heart disease, and then currently the age distribution is about 55 years or more. Men, in terms of gender distribution, are affected more than women, roughly a 2-to-1 ratio. The three major pathogens that occur or that result in infective endocarditis are the streptococcus, staphylococcus, and enterococcus. Others also include the gram-negative bacilli such as the HACEK group and fungi. We'll be focusing mostly on the bacterial endocarditis, so the streptococcus, staphylococcus, enterococcus, and the HACEK group. For infective endocarditis to occur, there has to be some sort of damage to the valve, whether through trauma, infection, or drugs. But when this occurs, a thrombus forms on the surface of the valve and allows adhesion of bacteria to the valve. Once bacteria establishes a colony, vegetations in the form of fibrils start to form. And the evidence of vegetation is the hallmark sign of infective endocarditis. And this can actually be seen on the figure on the first slide. The risk factors for endocarditis are highlighted on this slide. Valvular abnormalities such as mitral valve prolapse and rheumatic heart disease. Demographic characteristics such as hemodialysis dependency, diabetes mellitus, or poor dentition. And then also IV drug users. Currently, there has been a rise seen with healthcare-associated IE, mostly from IV catheters, pacemakers, and dialysis shunts. And the following are clinical presentations associated with endocarditis. It's important to note that not all patients will present with these signs and symptoms. Other diseases can cause these as well. The symptoms highlighted here are not specific to infective endocarditis. Pertaining to the signs, Osler nodes are painful, raised lesions found on the hands and feet. Janeway lesions are non-tender lesions on palms or soles. Petechiae are small, red, purple spots caused by bleeding in the skin. Roth spots are retinal hemorrhages with white or pale centers, and splinter hemorrhages are tiny blood clots that tend to run vertically under the nails. These figures represent some signs that manifest with infective endocarditis. In figure A, as you can see, shows a clubbing of fingers, and then figure B shows petechiae on the toes, and figure C is a picture of Osler nodes, as you can see right there. For endocarditis to be diagnosed, the history of the patient has to be taken as well as the physical examination. Diagnosis uses the Duke criteria, which is divided into major criteria and minor criteria. For the major criteria, at least 2 positive blood cultures need to be drawn at least more than 12 hours apart. And for evidence of endocardial involvement to be seen, an echocardiogram, either TEE or TTE, has to show positive in order to diagnose for IE. For the minor criteria, there has to be some sort of predisposition, vascular phenomena, or immunologic phenomena. Echocardiograms can also help identify the presence of vegetations, valvular destruction, and associated abscess, fistula, or perforation. The following lists complications associated with IE, such as congestive heart failure, risk of embolization, myocardic aneurysms, and other neurologic complications such as seizures and encephalopathy. These are the treatment goals of IE. They include anywhere from minimizing or preventing valvular damage and complications, preventing recurrence of IE in high-risk patients, and of course the eradication of infection and decreasing morbidity and mortality, and relieving signs and symptoms. For this lecture, the therapeutic options have been broken down as first line being pharmacologic treatment, and then second line for surgery. The drug of choice for IE is tailored to the causative agent. So for Streptococcus and Enterococcus endocarditis, the drug of choice happens to be beta-lactams. And for Staphylococcus endocarditis, the drug of choice are penicillinase-resistant penicillins. In general, the duration of therapy for prosthetic valve endocarditis will be longer than that of native valve endocarditis. And from this point on, I'll be using NVE as an abbreviation for native valve endocarditis and PVE for an abbreviation of prosthetic valve endocarditis. This is the breakdown of the native valve endocarditis treatment for Streptococcus. As you can see here with vancomycin, it's recommended for patients unable to tolerate penicillin or ceftriaxone, which are the mainstay treatments for strep. The trough level goals for vancomycin are between 10 and 15 micrograms per milliliter. For gentamicin, which is a tiny little thing you see right here, are typically used for synergistic activity with cell wall active agents such as beta-lactams. They increase in bactericidal activity, decrease emergence of resistant organisms during treatment, and increase pace to clinical and microbiological response. Their use is typically in a short duration, and the peak levels for that should be between 3 and 4 micrograms per milliliter, with trough levels of less than 1 micrograms per milliliter. And this is the breakdown treatment for PVE caused by Streptococcus. Note that for the treatment of PVE caused by Streptococcus, they also use the beta-lactam agents that were seen in NVE. But the penicillin doses in this case are higher and the duration is longer. This is the treatment for Staphylococcus NVE. For cefazolin, it may be substituted for patients with non-immediate hypersensitivity reaction. Otherwise, the vancomycin should be used if unable to tolerate beta-lactams. And as you can see here with the gentamicin, here you have an option of using that with the cefazolin or the nafcillin or oxacillin. And this is the breakdown treatment for PVE caused by Staphylococcus. Unlike the NVE treatment as previously seen on the last slide, where the choice of optional gentamicin exists, in the PVE treatment, gentamicin must be used in addition to rifampin. Enterococci has about 3 different treatment plans. So here you can see it's broken down based on the NVE and the PVE have the same treatment, almost. With this, it's broken down to susceptible to penicillin, gentamicin, and vanco, or susceptible to penicillin, streptomycin, and vanco, but it's resistant to gentamicin. And I created these flowcharts to make it easy to distinguish between which is which. For this slide, these treatments are for when there is a penicillin resistant, but the bacteria is susceptible to aminoglycosides such as the gentamicin and the streptomycin, and the vanco. Note that here the ampicillin sulbactam is 3 grams, not like 2 grams like the previous slide. These are your VREs, your very resistant enterococci. And these are pretty much just resistant to the treatment highlighted in the previous slides. And here, instead of using the vancomycin, the ampicillin sulbactam, you're using drugs such as linezolid and daptomycin and imipenem cilastatin, those sort of drugs. For the HACEK endocarditis, the treatment plan for the NVE and PVE are also the same. The HACEK microorganisms are Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. For this treatment, with ceftriaxone, other third or fourth generation cephalosporins may be used as an alternative. For Cipro, they're recommended for patients with known intolerance to cephalosporins or ampicillin, and other fluoroquinolones may be used as an alternative. However, notice that the dosing for Cipro here and here changes depending on the route of administration. And in general, the treatment is longer for prosthetic valve endocarditis than the native valve endocarditis. For surgery, which is the second-line treatment option, they're generally used post-treatment with antibiotics, and they're aimed at the debridement or removal of all infected tissue, drainage of abscesses, repair of the heart tissue, and valve reconstruction where you're repairing or replacing the affected valve. These are the monitoring parameters, so obviously your signs and symptoms and blood cultures. With the vancomycin, you definitely want to watch out for the infusion-related reactions, lab tests such as CPK, LFTs, renal function tests, and then the trough levels and or peak levels with the serum drug concentrations, mostly with the vancomycin and the aminoglycosides. This is a summary slide of what you should get at the end of this lecture at some point. So the major pathogens, some major causative pathogens are the species from streptococci, staphylococci, and enterococci. The hallmark sign of IE being the vegetation. Clinical presentations range from the nonspecific, such as the fever, night sweats, shortness of breath, nausea, vomiting, to peripheral manifestations such as the Osler nodes, rot spots, and drainway lesions. Antibiotics therapy must be bactericidal, so they're supposed to kill the bacteria, not necessarily just stop the growth of it. Dosage regimen must be sufficient to maintain bactericidal antibiotic activity throughout the dosing interval and duration of therapy. And treatment usually lasts 4 to 6 weeks, depending on whether the infection occurs in the native valve or the prosthetic valve. And then unsuccessful treatment of infective endocarditis can lead to complications that may occur, that may require surgery. And this is the same patient case presented in the first couple of slides. Just read through it. The questions on this slide will be discussed in class on Friday. We'll see you all there. Thank you.